Thank you, Dr. Ferry, for introducing me, and I would also like to thank SAGES for inviting me from Europe to chair this session. I'm really looking forward to it and to see the different videos and approaches to esophagectomy. These are my disclosures, and they should all not affect the talk that I'm giving today. To give you some background where I'm coming from Cologne. It's in the very west of Germany. It's just an hour drive from the Netherlands, Belgium, Luxembourg, and France. And our center is a high-volume upper GI cancer center, probably the largest one in Europe. And we just launched a randomized controlled trial dealing with type 2 esophageal cancer and the best way to treat that. And I'll come back to that later. We are comparing transhiatal gastrectomy with Ivor-Lewis esophagectomy. To give an idea about the numbers that we operate on, I prepared this slide. Last year, even with COVID, we were able to operate on more than 200 patients with esophageal cancer. And I started my practice in 2016 and had the job to increase or to decrease the open cases and to increase the totally MIS caseload in Cologne, and we performed 74 robotic esophagectomies, Ivor-Lewis, last year. This is just a quick intro, and I will use this slide to show you the different studies that are out there comparing those different treatment options. And I'll start with open McKeown and going to Ivor-Lewis as a newest development of esophagectomy. In 2012, there was the TIME trial coming out of Susanne Giesbert's institution in Amsterdam. The first trial that compared open McKeown with total MIS McKeown. And just like all the other studies that were present, they had less pulmonary complications and showed an overall favorable outcome for minimally invasive cases. Then the MIRO trial, published from a French working group, the Frégate working group, published in JAMA Surgery in 2020, compared open to hybrid esophagectomy, and hybrid meaning laparoscopic abdominal and thoracic open. And interestingly, in that trial, the patients also had less pulmonary complications, even if the thoracic part was performed open in that trial. And then the robotic studies are coming out, again from the Netherlands, this time from the Utrecht group, comparing open McKeown versus robotic McKeown, and again, less pulmonary complications and comparable oncological outcomes when comparing the two ways of doing esophagectomy. The latest trials compare total MIS esophagectomy Ivor-Lewis with robotic Ivor-Lewis. To be honest, I think it's really just a nuance, and that is what's coming out of this trial from China, published in Annals of Surgery, where they were able to show that there might be a little increase in lymph node yield after robotic esophagectomy. Another trial is still recruiting, the Romeo trial from UK. It's a 3-arm study, and the results are still expected. Another 2 trials, interesting trials, are coming from Germany. The ROBOT 2 trial is again comparing total minimally invasive esophagectomy Ivor-Lewis with RAMI, and the primary outcome measure will be number of resected lymph nodes. I'm really curious about the results of that trial. And I think a very interesting trial will be the MIE trial from Heidelberg in Germany, multi-center randomized controlled trial comparing hybrid Ivor-Lewis with total MIS, Ivor-Lewis, either robotic or MIS, and I think that will be a really interesting trial comparing those different ways. So I would like to already come to an end. Overall, I have to say that Ivor-Lewis transthoracic should be the standard of care in a multimodal setting. Some questions, though, have still to be answered. Cross versus flawed is a question that is still unclear. What to do with the clinical complete responders? There are quite some studies out there how to deal with these patients. The right MIS technique for esophagectomy, I think, is something that should be a very personal decision of the surgeon, but it still needs to be answered. And the extent of the resection for the type 2 cancers will hopefully be answered with our CARDIA trial. I would like to motivate all of you here in this room to contribute to international registries. Those are the registries that we are contributing to from Cologne. Really good studies coming out there, as you can see here. So this is my very personal opinion, how to perform esophagectomy. I prefer to do the abdominal part laparoscopic, and then you can choose the right laparoscopic tool or tower that you like, 3D, 4K, ICG, whatever you want. And then I do the reconstruction and the resection phase with the robot, and I can again use ICG for lymph node mapping, as you can see here in the picture, or for vascularization. Thank you very much, and I'm really looking forward to the rest of the session.